So like we are targeting to all the categories over here. Okay, sir. Just to tell you, we are live on Facebook. A very good evening and a warm welcome to everyone. On the occasion of World IBD Day, that is Inflammatory Bowel Disease, we have come up with the initiative known as IBD Talk and enumerated expert clinical views on inflammatory bowel disease. And today, we are very fortunate to have with us Dr. G. N. Ramesh as a clinical expert. To begin with, I would like to introduce and welcome the clinical expert for today. Next slide. So, Dr. G. N. Ramesh is the head of department, Astor Center of Excellence in Gastroenterology and Hepatology, Astor Medicity, Cochin. He is a past president of the Society of Gastrointestinal Endoscopy of India and a member of Governing Council of the Indian Society of Gastroenterology. In the recognition of his academic and extracurricular achievements, he was bestowed with the Economic Times Inspiring Gastroenterologist Award during the All India Doctors' Day conclave held in New Delhi on June 30th, 2022. He has 16 publications in leading scientific journals, numerous guest lectures, several memberships to professional societies, and a large number of successful organized scientific conferences to his credit. He is a very active in many service organizations as well. A Rotarian since 2000, he chose Rotary Club of Cochin Metropolis as his home. He has organized and convened the Cochin Gut Club, a unique venture involving gastroenterologists in and around Cochin with the aim of exchanging and furthering academic ideas leading to medical and surgical enterology. With this, I would like to now welcome Dr. G. N. Ramesh and would like to introduce the topic of today's session is living with IBD, disease perspective and preventive steps. Sir, over to you.
Thank you very much, Ms. Anjali. An absolute pleasure to be involved with you and your group on the occasion of World IBD Day. Could I please share my screen? If I could be able to share my screen, I will just go straight. So, as you all know, that World IBD Day is observed on May 19th, year after year. And that is an occasion where we rededicate ourselves to the management of inflammatory bowel disease. This year, the theme for this, for the World IBD Day is IBD has no age. And how true it is, isn't it? I've not been able to share. It shows host disabled participant screen sharing. Could my sharing be enabled?
Yes, sir.
So I deem it a great privilege to be a part of this IBD day celebrations or the function which Saffron has come out with. The idea is wonderful, and I would like to first of all congratulate them. So yeah. Right. I hope my screen is now visible.
Yes, sir. It is visible, sir.
Yeah. So IBD has no age, and it's amazing to see so many people from different countries come together in order to raise awareness for these devastating diseases. And that is why I said I would like to congratulate Saffron for this effort and the initiative that they have taken. And I wish this initiative all the best. And I wish that it percolates down to the patients, their caregivers, the patients' bystanders, as well as the doctors, because there are a lot of messages involved which I need to give through my presentation. My scheme for today is, first of all, a little bit of ulcerative colitis and Crohn's disease, and a little bit of the challenges that we face today, especially in IBD in the young, and maybe a few points of action. Traditionally, IBD was a disease of the West. And in fact, the initial publications all came from the West. But it is only a few years back that we in India found that we are seeing more and more cases of inflammatory bowel disease, especially Crohn's disease. Why is it so? Probably urbanization and its consequences, and of course, whatever it is, the lifestyles that have changed and the environment that has changed. There's been so much of debate about how Asia got fat, our intake of junk food, as well as the pollution. So I think, needless to say, that not only are we following the West in the lifestyles, we are also following the West in the disease styles as well. And that is why we in India are now seeing a lot more patients with inflammatory bowel disease. So therefore, IBD is on the rise in the Asia Pacific region. And if you look at India, it is even more. And you find that most centers, whether it's north, west, east, or south, you have a fairly equal distribution. But in south, where I practice, we are now seeing more and more patients with Crohn's disease than ulcerative colitis. For example, the east, you see more of ulcerative colitis. From the north, you see more of ulcerative colitis. In the west also, you see more of ulcerative colitis. In the south, we see quite a lot of patients with Crohn's disease, even though it's roughly about 50-50, if you say. Now, added to that, we are now seeing this disease in the pediatric age group, an increasing number of Crohn's disease in pediatric age group. And here you see that, the green bar is Crohn's disease, the blue bar is ulcerative colitis, the short white is indeterminate colitis. Forget the indeterminate colitis, but you ultimately find that children with Crohn's disease are now being seen more often. And this is another important take-home message that we need to take cognizance of. EOIBD is early onset IBD, late onset IBD, and you find that actually in patients with Crohn's disease, you find there are quite a few with early onset IBD. And this early onset IBD, you find that 3/4 of them have a severe disease phenotype. And this is another thing that we need to take note of. That is, the earlier the disease manifestation, the more severe it tends to be. It is affecting almost the entire disease spectrum. And that is why the theme for this year's IBD Day is actually the IBD has no age. You can see IBD in the very young. You can see IBD in the elderly as well. Why is it that we are seeing? I think the answer revolves around lifestyle changes, migration patterns, the diet patterns, the industrial exposure, the hygiene. Not to forget about smoking, the overuse of antibiotics and non-steroidal anti-inflammatory drugs, avoidance of breastfeeding, tendency to put the children or to put the newborns on prepared feeds and not the breastfeed. So basically, we have been westernizing. That westernizing has affected our environmental exposures, which influence the microbes, microbiome, and this incites inflammatory bowel disease in a genetically susceptible individual. But I think it all revolves around microbiota. I think today is not the occasion for to talk about microbiota, but if I can just give you a perspective, the Indian perspective, unfortunately, despite the fact that we are seeing a lot of patients, IBD is still not considered a major public health problem. There are no true population-based registries. We are trying to develop one. There's limited access to healthcare facilities for most people. The physician awareness is also poor. It's only over the last 2 or 3 years that people have become more aware about inflammatory bowel disease. And because of the fact that we also have continue to have problems of infective diarrhea and tuberculosis, there is always this confusion. Is it Crohn's? Is it tuberculosis? Is it ulcerative colitis? Is it an infection? The important thing that we need to note and keep in mind is inflammatory bowel disease is a chronic lifelong disease, underlying lifelong disease. And the problem is that the delay in the diagnosis and treatment are associated with long-term complications, and disease is more often than not picked up at a stage where perianal abscesses have occurred, fistulae have occurred, and then in that stage, they may require multiple surgeries. So we need to pick them up early in the course of the natural history of the disease. This also results in growth retardation in children, and there is an increased risk of colorectal cancer in long-term disease, particularly those with ulcerative colitis. The symptoms of inflammatory bowel disease are plain and simple: diarrhea, mucus, and blood. Abdominal pain, more often seen in patients with Crohn's disease. Fever could be seen in patients with Crohn's disease and ulcerative colitis, and weight loss. It often mimics a common infection or amoebiasis or tuberculosis. So very often you'll find this patient sitting back thinking it is just another infection when actually he or she is going through the first few phases of inflammatory bowel disease. And that is the time when we need to pick the disease up and initiate treatment if we are to decrease complications. So therefore, the key to diagnosis is therefore an initial diagnosis. We assess the extent and the severity of the lesion, diagnosis of any other complication, and then once we've started, we have to do monitoring. This is a classical picture of an ulcerative colitis. You find a diffuse mucosal involvement and multiple ulcers. And here you have Crohn's disease. You find big, huge, deep ulcers with nodularity. You see the difference between ulcerative colitis and Crohn's, and this is a normal colon. And here you find a diffuse disease. Here, actually, the disease can be actually quite bad. Now, the phases of inflammatory bowel disease management are two. Our first job is to induce a remission. The disease is active. There are a lot of other laboratory abnormalities. The patient has got symptoms. We need to start the treatment and induce a remission. And once we have induced a remission, then we enter to the second phase, which is called the maintenance phase. And that can go on for a long period of time. Normally, as physicians, as gastroenterologists, we believe in this particular type of treatment that is called the step-up treatment. We start with the steroids or aminosalicylates, and then go in for systemic corticosteroids, and then add on thiopurines to maintain remission. And now we have the new molecules that have come up, the biologics and also the small molecules. All the biologics have to be given parenterally. The small molecules have got the advantage that they can be given orally. The small molecules are only coming up now. The biologics are already established as an important group of drugs that cost, and crucial to it is selecting the right drug, giving it at the right dose, and then also giving it and adopting the right strategy. I did mention about rise in the incidence of IBD in India, and these are the many reasons why actually we are seeing a lot more patients with inflammatory bowel disease in India. We still don't know why it has happened, but probably it revolves around environmental factors, the microbial antigens, the genetics, and also the mucosal immune response. All of them combine together to generate what is called as an immune response in the mucosa, and that gives rise to infection. This is a typical specimen of a patient with ulcerative colitis, which was resected because of a severe disease. And you find that on the left side, actually, there is gross, almost a diffuse involvement. And something like this, closely, you'll find that lot of small polyps and multiple ulcers. And this is a much more closer, and you find that these are called pseudopolyps. And unlike the normal polyps, these pseudopolyps are actually inflammatory. And you find that in pathology, the classic pattern is like this. This is a normal pattern. You find all these crypts stacked against each other in a nice regular pattern, almost like a sari design. But here you find what has happened is that parallelism, the orientation is lost, and this is what is seen in patients with ulcerative colitis. One of the big challenges that we face in clinical practice is whether to differentiate between ulcerative colitis and Crohn's disease. Needless to say that you could have a patient who fits in very well with all this and therefore is diagnosed ulcerative colitis. A patient who has got skip areas, patchy areas of involvement, transmural involvement, has got fistula, fissure, very clearly Crohn's disease. But let me tell you, about 30 to 40% of these patients, there is a great deal of confusion. They may have some pointers towards ulcerative colitis, they may have some pointers towards Crohn's disease. And in these patients, actually, we say it's either indeterminate colitis, the large gray area between ulcerative colitis and Crohn's disease. And in due course of time, actually, they move either to Crohn's or to ulcerative colitis, and just a matter of time. A very interesting observation is about smoking. Now, smoking is associated with a higher risk of Crohn's disease, but lower risk of ulcerative colitis. So jokingly, we people say that smoking is probably protective against ulcerative colitis, but the fact we never use that as a reason or an excuse to encourage smoking, because smoking all round is considered bad, and we don't look at smoking as protective towards ulcerative colitis, but certainly it makes Crohn's disease worse. Now, radiology is one very important way by which we diagnose patients with ulcerative colitis or Crohn's disease. And this is a CT scan. With the advent of CT scan and refinement of CT scan, we find that we can get such good images of the colon. You find that this is the colon, and you find there is thickening of the walls with lot of pseudopolypi here. This is a classical presentation of an ulcerative colitis. And we find we always believe that ulcerative colitis is something that is restricted to the large bowel, but sometimes they can have backwash, ileitis, and inflammation in the distal ileum as well. And here you find there is thickening of the distal ileum, and you have hyper enhancement, which means that there is inflammation. Similar picture here also. Colonoscopy, I did mention ulcerative colitis, very typical findings, and this is small ulcers. It's a granular mucosa. And this is a normal colonoscopy on the left side. On the right side is a typical patient with ulcerative colitis, and find multiple small ulcers. The treatment still revolves around inducing a remission with steroids, maintaining it with 5-ASA, and in some patients with azathioprine, restoring and maintaining nutrition, maintain the patient's quality of life, and also give them a lot of counseling, because the moment we tell them that this is going to be a lifelong problem, they go into depression. So it is very important that we actually give them a good counseling. And in some patients, they may end up with surgery. So medical treatment is about 5-ASA and corticosteroids to induce a remission, thiopurines to or azathioprine to maintain a remission. And today we have this group of molecules called biologicals, which are basically monoclonal antibodies, which are used for the management of chronic inflammatory disorders, be it ulcerative colitis, Crohn's disease, arthritis, and with good results. And in the difficult to manage patients with ulcerative colitis, we have often used infliximab or adalimumab, and now we have vedolizumab also. And in some patients, actually acute severe ulcerative colitis, we can use cyclosporine as well. Surgery only in patients who have got severe bleeding, uncontrollable, failure to control severe attacks, or a patient with toxic megacolon, or the unfortunate patient with perforation, chronic symptoms despite medical therapy, so it's a refractory disease, medication side effects without disease control, so you've not been able to achieve control, but already the side effects have set in, especially steroids, when there is suspicious dysplasia or growth retardation. But the first three will probably be the most important indications for surgery. Moving on to the sister disease of ulcerative colitis, Crohn's disease. In our days when we were being taught medicine, we were told that any patient with suspected Crohn's disease, it is not Crohn's disease, it is tuberculosis. If you say Crohn's disease, we will fail you in the exam. That's what we were told. But today, I think it's the other way around. We are seeing more of Crohn's disease. And Crohn's disease is something, it's an inflammatory bowel disease that can affect the bowel anywhere from the mouth to the anus. It is transmural. We are seeing a lot more patients now. Males and females are equally affected. Smokers are 3 times more likely. So therefore, for all patients with Crohn's disease, we say you stop smoking. And the initial disease presentation usually occurs in the teenage group and the 20s. If you look at the disease distribution, it's known for a patchy involvement. The most of them are ileocolonic, which is this purple. So it is basically this difference which we need to keep in mind. And what is important about Crohn's disease? The inflammation is transmural, which means that it is across all the walls. And here you find a classical resected specimen of a patient with Crohn's disease and ileocolonic, and you find that there is a stricture here. This is where the stricture was. Here again, this is an area of involvement. You find that this area has been narrowed, the wall is thickened, and there's a lot of inflammation around. It could be stricturing disease, like where you have a stricture narrowing and the patient presents with obstruction. It could be a penetrating disease resulting in fistula or purely inflammatory disease, just like ulcerative colitis. The clinical presentation could be acute or chronic. Acute. In fact, many of our patients with appendicitis, some of them could be actually the first presentation of Crohn's disease, recurrent attacks of pain and diarrhea, low-grade fever, or an abdominal mass. And there are lots of complications. You could have stricture, fistula, perforation, abscess, neoplasm, and extra-intestinal manifestation like arthritis, ankylosing spondylitis, sclerosing episcleritis, cholangitis, stones, erythema nodosum, and pyoderma gangrenosum. And surgeons are generally wary about operating on Crohn's disease because they are also prone to post-operative complications like anastomotic recurrence, anastomotic fibrostenosis, and additional obstruction. The most horrible form of Crohn's disease and the challenging form of Crohn's disease is those with fistula. We call it fistulizing Crohn's disease. And fistulizing Crohn's disease automatically puts it at a more severe form. So you could have internal fistula, you could have external fistula. The internal fistula is intestinal or extraintestinal, enteroenteric or enterocolonic, small bowel to small bowel to large bowel, small bowel to the urinary bladder, rectum to the vagina. Anywhere actually the fistula can develop. But once a fistula develops, they become very, very difficult to treat. Ulcers, relatively more simple to treat because they just present like ulcerative colitis, and you could have aphthoid ulcers or fissures. We diagnose patients with Crohn's disease based on CT, and that gives us the idea of the extent of the disease and complication. The treatment of Crohn's disease is almost the same as that of ulcerative colitis, but if a patient has got fistulizing disease, we generally tend to use the more severe forms of treatment much earlier, which is called the step-down therapy. That is, we start with the more expensive medications, the more powerful anti-inflammatory like the biologics earlier, get the disease under control, and then bring it down. So normally for the common garden variety, 5-ASA, prednisolone, immunomodulators, but should that fail, we go into infliximab or adalimumab or even methotrexate. But in severe forms, we generally tend to start with infliximab, adalimumab, and then step down later. Crohn's cannot be cured by surgery, that is definite. The role of the surgeon is only to manage complications of Crohn's disease, but ultimately they have to be on a lifelong therapy, medical therapy, which needs regular follow-up, frequent counseling. IBD has no age. And therefore, it is important for us to understand that our biggest challenge when we manage inflammatory bowel disease is to manage these young adults with Crohn's disease. And the young adults with Crohn's disease have now actually organized themselves into a Crohn's and colitis young adults network. Because you would understand that a person who is 20 years old or 15 years old or 16 years old, in the prime of youth, having dreams of education, having dreams of employment, having dreams of a good life, having dreams of romance, and then comes this problem, which is a lifelong problem. You can imagine how much of a psychological problem it is for these patients. Had inflammatory bowel disease, and she was so frustrated. She said, meet me in a place where I'm a person, not a problem to be solved. We always tend to look at them as problems, not persons. And this is another thing, because IBD has no age. We have to deal with very young people, with children. We also have to deal with elderly people who do not have much of social support also. So we need to find out what is the problem, what is their social status, what are the challenges. 25% of patients are diagnosed with IBD before the age of 16. So you can imagine the number of patients, young patients. So therefore, what we encourage them to do is we organize support meetings, get them involved in the support meetings where we have other patients address their problems, address their concerns, the psychologist, the dietitian. And this is basically now has launched into a major international fellowship. It is a fellowship program for young IBD patients, which looks at relationships, which looks at the school curriculum, which looks at work, financial independence, identity, and also besides treatment. Let me tell you that in India, we are only looking at this part. We don't look at the others. I think it's important that on this IBD day, we rededicate ourselves to the cause of the young IBD patients and the very elderly IBD patients, the very elderly who do not have social support, the young IBD patients who have got a lot of dreams but are depressed because of the fact that they are suffering from a lifelong disease. So young adults with a chronic illness are at an increased risk of developing psychiatric disorder, and that is why psychiatrist or a psychologist needs to be an integral part of management of patients with inflammatory bowel disease, because they could have suicidal thoughts, they actually may have problems and they may commit attempt suicide. So all these things are very, very important, and they need peer support, they need mental health care, and they need a lot of other support. It is important. Now look at this. This is a child with IBD who is now looking like this. This is an Indian girl who's now looking at this. So if you manage them well, they can grow up normally. They can overcome all the physical as well as the mental and social challenges. The key point is that we need to recognize that this transition is a long process. Start introducing time alone with patient early on. And we need to spend a lot of time. Talk to them about alcohol, talk to them about sexual health, talk to them about mental health, as well as the social life. And tips, these are the tips which the young adults with inflammatory bowel disease have actually given us. Emphasize importance and define the role of a primary care physician within the adult system. There must be prioritization time alone, or that patient cannot be a part of a big OPD or a general OPD. Incorporate young adults on advisory boards. Remember, patients are also experts and they have got a lot to advise us also about. And of course, besides a lot of other things, including affordability. These drugs, let me tell you, are not cheap alternatives. They are expensive. Mesalamine is expensive. All derivatives of mesalamine are expensive. Biologicals are expensive. So we must bear in mind that the idea of having to consume these drugs over a long period of time, spending a lot of money is quite daunting, and especially when they don't respond well, it becomes very depressing also. So we need to look at the financial angle, and also not to forget nutritional disorders. They will not be eating, pain abdomen, diarrhea, no appetite, sometimes just pure and simple depression. They will not eat, and this ends up with a lot of malnutrition. So what are the takeaways from my presentation that I would like you to remember is, I think it's important that we look at it from the patient's perspective. Ask your patient what is important to you, what is it that is bothering you, what is it that you want out of the treatment. Promote your patient's sense of agency in their care and identity. Invite them for support group meetings. Speak in simple language, same language, and of course address various other issues, including peer support and parental support. This is a list of the 2022 fellows, and you'll find that there's one Indian here, and there is one Indian here. There are two Indians here. So you find that Indian presence in these international fellowships is increasing. So I'll end my presentation on this IBD day, where I just try to actually give you a broad overview about inflammatory bowel disease, but also try to give you a few important social messages that I believe are important. IBD is on the rise in the developing world, affecting the young active age group. It is a chronic lifelong disease, but it can be managed if it is picked up early in the natural course. Any case of chronic or recurrent loose motions, bloody diarrhea, and weight loss needs colonoscopy and further evaluation. Early diagnosis can improve outcomes. Adequate treatment, adequate monitoring, drug adherence is of utmost importance to ensure that the disease is controlled. It is not only disease control that is important, also follow-up as well as psychological support that is very important. And most patients will do well. In fact, most of my patients, fortunately, because I have got a support team that picks these patients up at a very early stage in the natural history. And now physician awareness is there, pediatric awareness is there. So adequate treatment can lead a normal, healthy life. So I would like to end with this key message concept and World IBD Day. This year we are observing on with the theme called IBD has no age, and I would like to convey my best wishes of my team that I'm a representative of, the hospital that I'm a representative of, with a simple message that stay safe, stay healthy, stay happy. Thank you very much and best wishes on the World IBD Day. Thank you very much for hearing. And I am ready and for any questions and comments. Thank you very much. Back to you.
Thank you, sir. Thank you, sir. Thank you for the enlightening talk. Really enjoyed your talk, sir. It has touched all the points that everybody was thinking about to know about IBD. So one question has come from one lady. She is pregnant and she is having IBD.
Hmm.
So she is anxious. So how does, as a doctor, what will be the way you will be convincing him that it can be cured?
Okay. I don't know whether she has a Crohn's disease or ulcerative colitis. But
You see, sir.
okay. So I think uh, one thing is very, very clear, that most drugs that are used to control inflammatory bowel disease activity otherwise are safe in pregnancy as well, number one.
Right, sir.
Number two, if the disease has been under control at the time of conception, so at the time she became pregnant, if the disease had been under control, the chance of her having a relapse during pregnancy is also very, very minimal. On the other hand, if at the time of conception the disease is not active, not under control, it is moderately active or severely active, then I think the chance of a relapse or the disease becoming worse and the pregnancy outcomes being affected is much, much higher. But as of now, the message that we give is A, all the drugs are safe. All the drugs are safe. The mesalamines are safe. The azathioprine is safe. Steroids, of course, we usually refrain from giving long courses of steroids, but if steroids are required to control a relapse, I think it can be given. The biologicals are safe. Only methotrexate and the new one, tofacitinib, is something that has not been still recommended for patients with pregnancy. But my advice to the lady would be, don't worry. Ensure that you take your medicines in time. Don't stop the medicines, because your gynecologist or the obstetrician will tell you, be careful, don't take all these medicines. Let me assure you that all these medicines are very safe.
Thank you, sir. So another questions that is coming, that is a strict vegan or non-vegan diet. That is what you mainly advise to the
No,
patient to not to have patient.
I don't insist or I don't advise a vegan diet. I always tell my patients, you take the diet which you are comfortable with, which you want. The only things there are some things that need to be avoided. One, if the patient is sensitive to some food items, for example, 20 to 30% of patients with ulcerative colitis are they don't tolerate milk. So in which case, stop. In fact, seafood is supposed to be good, especially the sea fish. The seafood is good for patients with ulcerative colitis because they've got all these omega fatty acids. They're rich in all this, so they are good. I always tell them that you stick to the diet that you like, stick to the diet you are enjoying. Only thing is, avoid very spicy food, avoid a lot of junk food, eating out, and avoid if you're intolerant to any particular food item, avoid it. But there's no definite hard and fast diet regulation for patients with inflammatory bowel disease. Now, if a patient has got complications of inflammatory bowel disease, for example, a patient has got obstruction, then you have to change the diet accordingly. So all those things will be there. It all depends upon what is the nature of the disease, what is the complexity of the disease, and how well the patient tolerates some food items. Over to you.
Thank you, sir. Sir, do you think stress in modern day influences any chances of this IBD?
I didn't get you. What?
The stress in the modern day time.
Stress. Stress, let me tell you, is not a causative factor for inflammatory bowel disease, but stress makes an inflammatory bowel disease worse, especially ulcerative colitis. So stress is not causative of inflammatory bowel. But if you have a patient with ulcerative colitis who is reasonably well controlled, who goes through a stressful phase in life, the disease tends to actually become worse. So stress can cause a relapse. Stress can make a disease worse, but stress does not cause inflammation. There's a difference. So it's not causative. It can make it worse.
Right, sir. Sir, we have started at the audition with a word that IBD has no age. So why there's a paradigm shift is coming that the young adults, they are giving the population of the young adults has increasing day by day. So what may be the reasons you find for that?
For inflammatory bowel disease being seen more often in younger people?
Yes, sir.
Okay. There are three reasons why. Number one, I think the general level of awareness has increased. Now, you find that most pediatricians know about inflammatory bowel disease. Most patients also know about inflammatory bowel disease because they've been Googling and searching. So the general level of awareness is increased. And when the general level of awareness is increased, the more and more patients get reported. Second, we have now technology that can investigate a patient or a child with chronic diarrhea or recurrent abdominal pain more effectively, and therefore we pick up more and more patients. The third reason is obviously our changing lifestyle dynamics, and I think it has got to do with a lot with the style of eating, the dietary habits, and our so-called urbanization or westernization. So I think these are the reasons why we are seeing more and more patients at a younger age. I was also told one thing about all these additives, food additives. Now, ice creams, cakes, the bakery items, pastries, all of them have got, that cream with additives, which makes it more tasty. And some of them actually could probably be incriminated in the causation of inflammatory bowel. But the line is not clear. It is not a one-to-one relationship. It is just a presumption that many of the food additives are probably harmful to the gut bacteria. And when the gut microbiome changes, it sets into motion a process which results in gut inflammation, and long-term gut inflammation results in.
Right, sir. Sir, any chances of this specific intestinal infection can lead to the evolution in the IBD?
We have a condition which is called as a post infective, irritable bowel syndrome. Now, many of these patients who have an acute infective diarrhea, they recover from the diarrhea, but they may continue to have periodic gastrointestinal upset. They may continue to have diarrhea, sometimes recurrent abdominal pain, colicky pain, for as long as maybe even 6 months. Now, when we investigate them, we find a lot of non-specific inflammation in the ileocecal region or the acidic colon. Now, it is a presumption that maybe in a small proportion of these patients, it may progress on to a long-term inflammation. And some of these patients, a small proportion of these patients at later stage may actually present with inflammation. But then, again, this is an observation. It is not something that has been proven beyond doubt. But gut infections may be a trigger factor in the causation of infection.
So how do you give an importance to the patient counseling whenever any IBD patient comes to you? Importance in the patient counseling, Dr.
Ideally speaking, I think each and every patient needs to be counseled, especially the young ones. They need to be talked to along with their parents. They need to be spoken to alone in the absence of their parents also. And a psychologist should actually address their concerns and problems. Now, in a busy OPD, it is very difficult. So we end up looking at mainly the physical aspect, the disease aspect, the treatment aspect, but we do not actually look at their psychosomatic or psychosocial aspects. I try to look at that in as quickly as I can. But in some patients, 1 or 2 patients whom I believe and whom I feel need a lot more attention, I give them a separate appointment and then I sit with them separately. That way, at least once, if I can do that, I find that it makes a lot of difference because their confidence in the treatment goes up, their compliance with the treatment goes up, and they feel definitely more comfortable.
Thank you, sir. Thank you for giving us a lot of insights about the IBDs. Thank you, sir. Thank you.
Thank you very much.
Thank you so much, sir, for a very elaborate and detailed presentation on IBD. I, Anjali, on behalf of the entire team of Saffron, would like to propose a vote of thanks to you for joining us on the occasion of World IBD Day and describing in detail regarding the various complications associated with IBD. IBD being one of the serious conditions where there is no simplified cause and there is no simplified treatment. It is very essential to note and prevent this disease. So, sir, with your inclination towards academics and your inclination towards patient awareness and education, this initiative has been successful. And I'm sure the viewers who are joining us live on Facebook as well as on YouTube will take some keynotes out of this and will imply it in their daily routine. So, thank you so much, sir, for joining us today.
Thank you very much. My pleasure. My pleasure. Thank you very much.